I'm affiliated with a local IV and holistic medical clinic. And a couple of questions. One, what panels do you use for Morgellons and Alphago? And then I'll finish that with, even though I'm part of that clinic, my wife and I actually run a Lyme support group that went national because of COVID. So we started doing Zoom meetings, and we have guest speakers during the warmer months. And so I was wondering if you would be willing to be a speaker sometime. Thank you much.
Well, thank you so much. That's really very nice. Through IGeneX, I guess you can contact them, and we can set up a whole program if you like. So definitely contact IGeneX directly about that and give them the details, and then I'll figure out how I can help. So yeah, again, thank you. You know, a year ago, before COVID, I used to be traveling all around the country, sometimes even Europe, doing this. And with Zoom, it's so much easier. So if we can arrange the logistics and the timing and all that, I think would be great. So yeah, contact IGeneX directly and we'll work through them. So to your questions, again, thank you. Morgellons or Morgellons, I don't really, there's a controversy how to pronounce it. I don't really know.
Yeah.
Studies have shown two interesting things related to the tick-borne world. And of course, that involves Borrelia, but different types of Borrelia. So for that, you would want to do both the Lyme as well as the relapsing fever Borrelia. And if you look at their panels that they offer, the one that I would recommend is called LTP2 because it's the immunoblots for both, which is really the best test, plus also PCRs. And that way you get the broadest coverage looking for the Borrelia. The immunoblots are really, really important, but like any immune-based test, if someone is immune deficient, which some of the Morgellons patients might be, then you're more likely to pick up with a PCR. It's like a reciprocal relationship between serologies and direct testing like PCR. So, you know, to broaden it out and get the most pickup, you do both, a PCR and the immunoblot. If you can only if you can only afford or able to do one, then immunoblot would be the first choice. It is more sensitive. It also gives you a very broad range of what's going on there. The other thing you want to look for is Bartonella. And the thing that I found out doing some research, they offer a Bartonella fish test. Now, a fish test is where they take a drop of blood and they stain it with an RNA-based stain that then fluoresces. So it's very easy to see under the microscope and even computerized. But the thing I found out is that even can penetrate biofilms. The thing about Bartonella is that it's a major biofilm former, even in the blood vessels. I've actually seen photographs of like gelatinous masses of Bartonella in the bloodstream trapped with red cells and all. So to have a test that will get through the biofilm, which a PCR would not do, is really, really important. So I'd also test for the Bartonella, both by the Bartonella fish and by the Bartonella Western blot. The Bartonella Western blot that IGeneX offers covers a number of different species. And as we are learning, there's at least 30, some people say maybe 50 different Bartonella species. So the broader coverage you have, the better. Some studies have shown or suggested anyway that chlamydia may be involved as well. I don't think IGeneX offers anything special as far as chlamydia goes, but a standard laboratory can offer you that as well.
Awesome. Thank you.
Now, about Alphago, this is a very interesting thing. I actually have a whole lecture on just that one topic. Alphago is a sugar moiety that's present in the blood of hoofed animals and not present in primates like us, although sometimes I walk like I have a hoof. And the thinking is you get a tick bite and the tick had bitten a hoofed animal and then transferred that, that moiety to your bloodstream, and then you developed, or the patient developed antibodies to it, and then you can't tolerate Alphago anymore. Well, that's generally true, but what I discovered is that our own gut flora produces Alphago, and even Borrelia themselves produce Alphago. They did a study in dogs, and they found that what happened was, it's not that they got Alphago from the tick bite, it's that something in the tick saliva broke immune tolerance. In other words, what you had been once tolerant to, you're no longer tolerant of. And that was the Alphago. I've expanded that thought though, because so many of the Lyme patients we see have all these new allergies and sensitivities. They become allergic to dairy and to wheat and to soy and all sorts of other things. And obviously they have broken their tolerance. So when you're doing an alpha-gal evaluation, you can do alpha-gal antibodies. They're only useful if someone had a recent reaction, because those antibodies, the measurable ones anyway, disappear after just a few months, but the sensitivity can persist. But also what you'd want to do is assess them for food allergies, because not that it's part of alpha-gal, but might be a result of it, and might be some hidden diagnoses which you weren't aware of. And that would also imply some gut issues. So alpha-gal is much more than just a tick bite giving you some kind of a strange sugar from the animals. It's also perhaps involving your immune tolerance to a lot of things, and also the gut. So maybe I gave you more information than you wanted. It makes life a little bit more difficult, but
No,
at
you
least
told me
you'll be able
something.
to. Yeah, well, it helps you with your patients, and that's what's important.
Great. Thank you.
Great. Yeah, a couple of questions. I'm still relatively new in this whole space, and just trying to get sort of a gestalt on how to use the tests. So I also tend to have some patients that might be a little bit unusual. So I have one patient who has a diagnosis of multiple sclerosis, but in some ways it's atypical, according to the neurologist. And I did on my initial testing on her through LabCorp, I did a Lyme Western blot, and it came out very, very positive for IgG bands, including some specific ones. Let's see, just trying to grab this. So it had the P23 and the P93 and the P39, but it had a total of 5 IgG bands on the LabCorp, but no IgM bands. And the lady, she doesn't really have a lot of Lyme-specific symptoms. She just doesn't have like migratory paresthesias or pains, and doesn't have a lot of joint pain at all. But she does have mild facial asymmetry, which the neurologist is kind of just poo-pooing. So I figured I would get an IGeneX immunoblot, and which I understand is more specific. And I did so, and it was negative.
How do you like that, huh?
So should I just, can I just conclude that it was a false positive? But she had all these bands from my LabCorp. Not that often you see all those bands. And in the IGeneX, there was only a P41 band, IgG band, and no IgM bands. So any thoughts about that?
Well, MS very often involves a very highly activated immune system, B cells, T cells, and all. And when you have a polyclonal immune globulin excess, I don't know how to word it more accurately, as you would get with that kind of an autoimmune disease, you can definitely get false positive Western blots and IFAs and ELISAs. And that's the whole reason why they went to immunoblots, because they're recombinant antigens that are very, very specific. And you don't see that when you look on the website or where the immunoblots are published. But I have inside information. I won't tell you how I got it, but the immunoblot has not just like 5 or 6 bands. It's like dozens and dozens of bands, because different species have their own sort of mini immunoblot in part of it. So they go through such detail, and if all they found was just one band, I would tend to believe the immunoblot. Second thing is, I'd also tend to believe the patient. If she really has no Lyme symptoms other than her obvious MS, you have to be skeptical, because, in my experience, and I've seen Lyme patients since the 1980s, actually, there's always a multi-system involvement. There's always a little bit of something joint. There's a little bit of something non-specific, like low-grade fever or headache or neck stiffness, things that are not part of MS. If you go over the patient again with a fine-tooth comb and you think, maybe Lyme really still is there, then, you could repeat the immunoblot. But if you didn't already do it, the big disclaimer here is that, there's also the relapsing fever Borrelia, which can absolutely mimic Lyme and do even other things. So if you've done a Lyme immunoblot that was negative, but haven't done the relapsing fever one, then you really should, because old-fashioned Western blots and serologies can't distinguish one from the other. And nobody really knows what a relapsing fever patient would look like with a Lyme test from LabCorp or one of the other big ones. So number one, look at the patient. Number two, if not a relapsing fever test, and definitely do the relapsing fever immunoblot. And I would be very curious to see what happens. You should let us know.
Okay, very helpful. And if I can keep going,
Sure.
when I did the IGeneX testing on this patient, I also threw in Bartonella Western blot, and it was positive for IgG, and the species were Vinsonii and Hensley. Again, Bartonella, I've seen in literature there's some vague references of Bartonella having something to do with Lyme in some papers, but in this case, she doesn't have anything that pathognomonic for Bartonella. So seeing IgGs for Bartonella, I mean, should I just conclude that her immune system may have seen Bartonella in the past, or this could be another false positive?
The way to tell this would be by doing another lab test, and that would be the Bartonella fish test. Were you on when the other caller spoke about this? When I spoke to the other caller?
Yeah, just now.
Yep. Yeah, because the fish test is a direct test. It's not an antibody test. It directly looks at them in the bloodstream, and it does pick up multiple different species, including those. And it will not be affected by a polyclonal gammopathy or just a polyclonal increase as you see in autoimmune disease. Now, that being said, Bartonella is a lot more common than people thought. People doing blood work looking for controls, negative controls, found a very high percentage of them had undisclosed Bartonella. So it's very hard to say that it's a false positive, but in light of what might be a false positive Lyme Western blot, you want to really be careful, because these are decisions that might affect her treatment and her health and all that. So being more specific is really always important. So again, for the Bartonella, definitely do a fish, and for the Borrelia, then try relapsing fever Borrelia, add on. Very important.
Okay, and just briefly, the other patient I've been burning to talk to you about, I have a lady who has severe joint pain, especially in her lower back, and she's been through extensive rheumatology workup, and they can't find any reason for it at all. And I end up doing a workup with IGeneX, including a BART fish, and that came out positive. The species, I think it was the Vinsonii. Let me see if I can find this. It was one that there's literature that people who work with dogs, like veterinarians, have been found to get a polyarthralgia if they have this, and it's a fish test. So I imagine this means that she might really have organisms in her.
Yeah.
What would I do next?
Oh my goodness. Bartonella, I've seen some amazing photographs, or micrographs, I should say, of the Bartonella actually in the bone, at the articular surfaces, as well as within connective tissues in all different spaces. And so it's been said at the conferences that Bartonella can be a cause of joint pain even if you don't see synovitis, because it could be within the bone and periosteal tissues too. So I would tend to believe that. There's not, to my knowledge, any false positive Bartonella fishes. I don't know if fishes is the right word, but I would tend to believe that. And then comes the whole issue of treating Bartonella, which is so difficult. And there's no one recommendation that's above all others, except some generalizations. And that is that the different species of Bartonella, they very rapidly develop drug resistance during treatment. They live in all different bodily compartments. So for all those reasons, you need to treat probably with a combination of dissimilar antibiotics. There's a lot of literature on this, especially more recent literature. And ILADS, I believe, has a website where you can look up some relevant articles to that, and even maybe some presentations, because it's a very complex issue. And they're even working now on doing studies with herbal things. And they go through an FDA drug library and just see what hits. And they've found a few different hits of antibiotics as well as some herbal things. One of the problems with Bartonella, just like with Lyme disease, is that the organisms can go into a state of dormancy, non-dividing but still alive, and therefore antibiotics like the cell wall drugs that kill dividing organisms don't work. So they call these stationary phase organisms. And so they have in these studies choices of antibiotics to treat stationary phase Bartonella. So if you can do a literature search, look up stationary phase Bartonella, and you'll probably get more information than you'd like.
I guess I still consider myself a neophyte. I've taken the basic course, and I attended the online annual meeting this year, and I haven't done that apprenticeship yet. And I'm probably going to try and do that as soon as I can when COVID clears up. But it sounds like a heavy duty kind of situation. I haven't found anybody who's had the situation with somebody with bone or joint pain and possible positive BART that even has experience with this. Does this sound like something where I'm getting ahead of myself clinically, or have you heard like this?
It's all your level of comfort. Where are you located?
New Jersey, metropolitan New Jersey, outside the city.
There are different rheumatologists on the East Coast who you could think about making a referral to,
Mm-hmm. Like a Lyme literate rheumatologist.
Right.
Do you have any names?
Yeah.
Just have one more question that was emailed to me that pertains to some of the things that we were just talking about, from a doctor in New York, Dr. Stouffer. If my patient is negative for Lyme, should I reflex to a relapsing fever test? And I think that's interesting, just because they're both borreliosis, but they're definitely different strains. And so, Dr. Burrascano, do you have any comment on that?
This is a whole thing that kind of got my career started hundreds of years ago. I started practice in Long Island, New York, which at the time had the highest case rate of Lyme disease in the world. And we had tick surveys done where between 80 and 100% of the ticks they collected were infected with Borrelia. But how come maybe half the patients were seronegative, even by New York State testing, which at the time was the gold standard? Well, to fast forward all these years, I think what we were seeing as so-called seronegative Lyme really were the other Borrelia. And the reason why we say that, and why I say that, is because studies have been done almost by accident. They found patients who were diagnosed clinically as Lyme patients, who had all the signs and symptoms of what we see as Lyme literate and Lyme experienced physicians, yet they were always seronegative, but they were positive on direct testing for tick-borne relapsing fever. That was a big surprise, because classical learning and teaching is that relapsing fever causes these dramatic cycles every 5 to 8 days of high fever and then a crisis, and up and down it goes, and you can see the spirochetes in the blood during these, and so forth and so on. Well, that classic description is just the very tip of the iceberg. It's kind of like saying all Lyme disease has an EM rash. Well, we know most Lyme disease does not. Well, it turns out most relapsing fever does not have that classic relapsing fever cycle. And a perfect example of that is Borrelia miyamotoi. These were diagnosed as clinically seronegative Lyme patients, but now we know they were different Borrelia. So if you have a patient and you're clinically convinced they have a lot of the signs and symptoms of Lyme disease, but good quality Lyme testing is negative, then you definitely have to think of relapsing fever Borrelia. In fact, a study was done where they took 543 patients across the country, and 32% of them, these are Lyme patients, 32% were positive for Lyme, 22% were positive for relapsing fever Borrelia and did not have Lyme, and 7% actually had both. So you think about it's a 3-to-2 ratio of Lyme Borrelia to non-Lyme Borrelia. And again, these are patients who presented as Lyme disease, not as people who had classic relapsing, remitting, relapsing fever. So definitely, if you're thinking Lyme and Lyme testing is negative, you have to look at the immunoblots for relapsing fever. Second thing from the second call that we had, don't rule out Bartonella, because they can cause joint problems, fatigue, multiple body aches, and other things that look and act like Lyme. So that would be my recommendation, is reflex to relapsing fever Borrelia, and keep in the back of the mind Bartonella as well.